Well, good morning, everyone, and thanks again for joining us today for our KHP annual conference. I'm Seb Ourselin, I'm Professor of Healthcare Engineering, and I am as well the Academic Director of KHP Digital Health and Data Science team within the new structure of KHP. I'm delighted today to have great guests. We have 3 speakers, which I will introduce in a few minutes. But perhaps first thing, I would like just to give you a piece of a sense briefly about the activity we are running within KHP around that digital health and data science. So we really want to take advantage of, on one hand, the amazing opportunity of our data science knowledge and expertise and academic excellence within our main university, going from very advanced statistics, statistical models, up to very advanced deep tech technology of the lack of artificial intelligence, deep learning, natural language processing. And we want to apply this excellence into the digital health sector. And I'm sure that most of you are aware of our electronic health records installation, for instance, across our partnership, EPIC, and the opportunities this will bring to not only provide better tools to manage our patient today, but eventually better tools to prognose, to diagnose, to monitor our patients, and eventually to be able to identify, for instance, specific subgroups of the population which could eventually be treated using some specific new drugs, and working very closely with our industry partners to make sure that we can deploy those new technology in live within our environment. KHP is exploiting those amazing activity we have across our partnership of our 3 NHS Trust and KCL, and is not only working on the science, is working as well on the training, on the education. So we have a dedicated activity related to digital health and data science in this domain, when I'm pleased to have now a very large, active online digital health academy, which is available to everyone free of use. We had over 5,400 people who have been taking advantage of those training online, which is already quite, I feel, an excellent outcome. We have a dedicated activity around co-creation. How do we engage with our patients? How do we engage with our populations? I was very pleased to hear that public engagements and patient engagements is really becoming a core element of the KHP strategy. And was as well mentioned in our previous sessions. So we have outstanding colleagues who are really helping to make sure that our clinicians, our healthcare workers, our academics, our industry partners are engaging with our patient from day one, from the ideations, and that's what really co-creation is about, and making sure that they help us to make sure that those technologies are adopted. And as we heard on this excellent talk from the Honorable Julia Gillard, being able to get the message right and being able to explain to our colleagues and more importantly to our NHS users what it means, what the change will mean, and how we will eventually use those data science solutions to make a difference to them is going to be very, very important, and especially because it has to be done in close partnership with industry, and that's why we have a dedicated activity around entrepreneurships and industry engagements through our new London Institute for Healthcare Engineering, which is really pushing hard to make sure that patients understand the value of giving access to their data and what it means, and in a very heavily regulated environment that we are living in, it's really important. They appreciate that we need to have those technology certified by the UK CE mark, certified by the CE, certified by the FDA, if we really want to make a difference at scale with our infrastructure. And how do we use this infrastructure? We want to work very closely with our colleagues on the EHR system and on the EPIC, develop a research safe haven platform connected with the hospital life eventually, and being able to exploit the London AI Center for Value-Based Healthcare infrastructure we have developed to not only support the development of the technology, but as well its validation in a safe environment and eventually its live deployment. And success will look like having many first-in patients deploy life in our partnership across our 3 hospitals, across mind and bodies activities, and eventually being used across the NHS later on and globally. Today, we're not going to be able to touch on everything. We only have three speakers, but I think it's all going to resonate around inequalities and how do we tackle it with data. The challenge of bringing those digital health solutions into the community, so it's not all about the hospital. In fact, as I'm sure that you read in the Darcy report, it is going to be all about how do we bring some of those opportunities in our communities, and how do we treat patients and eventually prevent before they have to come to the hospital. So I think it's really, really important that we bring those technology into our communities. So our first talk is going to be presented by Professor Mark Ashworth, who is a professor of primary care at King's College London. Unfortunately, Mark was not able to join us today, so his talk has been recorded. And hopefully that will give you a very good sense about how can we use data to really understand and tackle inequality in our communities. In the context here, it will be about chronic pain and how this really needs to be looked at in a much more careful, with a careful lens, not just only as a novel statistics. And that's one of the reasons as well that we've got as well today after this talk, Angela Price-Rowe, who is part of our PICS group, which is a community group of patients looking at suffering from chronic pain. And it's a charity which has been funded and independent evaluations being undertaken to understand really the impact and benefit that can be delivered in Stockwell. And she will really give us, I think, a great life experience about what those type of research means and how this is hopefully positively impacting our day-to-day life. And then we will have Professor Prashant, who is a professor of affordable technology, and as well leading some of our new education program around medtech innovation and entrepreneurship, which will give us really a real-world experience, real-world event of how can you go from an idea into a product with our students at King's in partnership with our hospitals in the context of femtech, and how those data can be used to personalize the device and to provide support for our patient post-menopause. So great pleasure to introduce Mark, and now I leave it to listen to his talk.
Good morning, everybody, and I'm so sorry not to be with you in person this morning, but I hope you'll accept this as a poor substitution, my online presentation of my pet subject, chronic pain. Now, I've labelled my presentation Hiding in Plain Sight, and I think I better explain what that's about. I wonder if any of you remember back in about 2015-16, everybody who went on any management course was shown a picture of some very serious-looking management trainees, all working away at a common problem, NHS problem, no doubt. And then at the back of the classroom pounced a grizzly bear from the left of the screen to the right of the screen. And people were asked to say, well, what did you see in that? And everybody reports that they saw people working hard, and hardly anybody spotted the grizzly bear dancing around at the back of the screen. And very similar to that, I think we've got chronic pain. Chronic pain has been there long term and has been largely invisible to all of us who shine a spotlight on primary care. Now, why might that be? That's because I think in primary care, everybody has got a sense of what the common conditions that GPs deal with. And on my next slide, I've got a picture of the top 5 conditions. And as you can see, anxiety is the commonest condition that GPs deal with, and depression is number 3. So there's an awful lot of long-term mental health work in our jobs, toiling away at the coalface in primary care. It's not just mental health conditions. If I go to the next slide, you can see that there are physical conditions which commonly, I think, most people who are not in primary care would say, yes, this is what GPs do. They look after asthma and hypertension, and those too are high prevalence conditions, even if they're not quite as high prevalence as the mental health conditions. But have a look at what lies in between. What's number 2? And if you look at number 2, you will see it's chronic pain. Chronic pain has got the second highest prevalence of any of the conditions in primary care. Now, I'd better explain how I've got all this data. All this data comes from my research data set, where I'm research lead for Lambeth DataNet. Lambeth DataNet is a collection of anonymized data from every single GP practice in Lambeth. My goodness, this is hard-won data. The data is data that is given in trust by the GPs. We have to maintain that relationship of trust, and they continue providing data. You can see we've got 423,000 patients currently registered in DataNet. And for the chronic pain study, there was a subset of 360,000 GP patients, because some of the demographic data was missing. And we define chronic pain as those requiring analgesic medication, repeat prescriptions of anything stronger than what you can buy over the counter in at your local pharmacist. So anybody on repeat prescriptions of anything stronger gets on our chronic pain database. Or if they've got a painful condition, and this is a novel aspect of our research, which we did in collaboration with OBH, outcomes-based healthcare, and its painful conditions. So things like fibromyalgia, and people with fibromyalgia often don't have repeat prescriptions for analgesic medication and would be missed if you did any search purely based on medication. So what did we find? We have found that there's a strong link between chronic pain and ethnicity. Here I've put up a graph showing that in white females, the prevalence is 20.9%, whereas in Black African females, prevalence is 31.3%, and in Black Caribbean females, very different, 40%. So huge health inequalities based on ethnicity. Now, what about consultation rates? This is the completely new data, and GPs generally are unaware of what the annual consultation rate is for patients with with each of those common long-term conditions. Now, the top consultation rate, this, for any GPs in the audience, I think will come as a surprise. It's chronic pain. Anxiety consumes a huge number of consultations. So too does depression. And it's not so much conditions that we think we're forever tinkering with and managing, like hypertension and asthma. So we did this analysis, dividing healthcare professionals into GPs, nurses, and other healthcare professionals. The consultation mode was divided into face-to-face, telephone, and home visit. And it was then costed by a health economist. And the single most costly consultation in terms of manpower resources and in terms of consultation rate, by a long way, was chronic pain, with anxiety coming second, depression coming third. So chronic pain is a huge problem in terms of the consumption of primary care resources. The prevalence in the over 65s is much higher, which is hardly a surprise, but hypertension comes top. The prevalence in younger people is still number 2, with anxiety disorders, perhaps not surprisingly, the number 1 condition, not hypertension, as in the elderly. So to conclude, chronic pain is the single most costly condition in terms of primary care utilization rates, or put another way, in terms of consumption of the very limited resources of primary care. There are much higher rates in the over 65s. And rather than just ending with those 2 conclusions, let me end with a challenge. We've got to do something about this. Thank you very much.
Thank you very much, Mark, and thanks for taking the time to record this. We'd love now to hear from a living experience, and so I would like to have the pleasure of introducing Angela, who is going to give us a perspective on how hopefully research is making an impact in our communities.
Good evening, everyone. My name's Angela. By day, I'm a civil servant for the last 24 years, but full-time, I live with chronic pain. I have multiple health conditions, and my first experience with pain was a car accident. I was taking a driving lesson, and a coach hit us from behind, and that's when my neck and back problems begun. And from there, unfortunately, I've had additional health conditions which involve pain. It's had a big impact on my mental health. Where I was a bubbly person going out, I started to decline and have to stay indoors and be isolated because the pain was taking over my life. I suffer from different types of pain. So my gout pain is different to my neurological pain, which is different to my fibro pain. And if they kick off at the same time, I'm housebound. I can't come out and I'm on crutches. So I was living an isolated life because of chronic pain. And going to the doctors, they would provide me with medication which would make me drowsy. So you can't do much. And because I've always worked since I was 15, I wanted to go to work. But the medication was stopping me from going to work. I wasn't able to function properly. And my mental health declined. So I had to have like CBT to learn to function again. While having CBT, unfortunately, I was diagnosed with cancer. This was an additional pain, which was kidney cancer. So they removed my right kidney, and when I went back, my left kidney is working at 30%. An additional problem that I had to mentally deal with. Going to the doctors, they wasn't as helpful as I thought they should be. Not listening to my concerns and just providing more and more medication, which was making me drowsy, and that was affecting my work. And when you have an invisible disability, nobody cannot see it. So a lot of people won't believe you. So at work, people wouldn't believe me. They'd say, but you look fine. I'm saying, well, you're not listening to what I'm saying. And you find that medical teams, workplaces, even your family don't listen to you because they just see the outer look. So if I wasn't to explaining to you today that I've taken medication since I've come here with breakfast, so my pain level is about 5 at the moment. So, but if I didn't tell you I'm in pain, you wouldn't see that I'm in pain because I've learned to not be whinging all the time. It takes too much energy of crying constantly and moaning. I prefer to use that energy to something positive. So while I was living in isolation, I received a phone call. I describe it as winning the lottery. It was the Peace Project. reaching out to people like myself who live with chronic pain, and they were going to deliver a chronic pain program. So I was delighted. Although I was in pain, I was just excited of, you know, what can I learn? What can I do different? How can I get back to my normal self? Because I'm still young, you know. I'm 53, but I'm still young as far as I'm concerned. I'm still young. I still want to live life. I don't want to just be in the house and not doing anything at all. I want to help myself, and I'd like to live a long life. So I begun the Peace Project. It's an outstanding project which I believe should be rolled out throughout the whole of Lambeth. In fact, throughout the whole of London, I believe it should be rolled out. At the moment, over 1,000 people have taken part on the Peace Project. We now call ourselves the Pain Family because we're able to engage with people who live with pain, who understand pain, because for some reason nobody doesn't understand pain. So to give you an example of the pain that I experience, we've all experienced a toothache. Imagine your toothache 10 out of 10, and it's the whole of your body. Nobody can see it. Nobody can understand it. So I've had to figure out a way to explain to medical team, to family, to workplace, what I deal with on a daily basis. That's the type of pain. It's a throbbing pain all the time. It doesn't go away. On top of it, I have pins and needles, I have weakness, I have stabbing pains as well as dull pains, all different types of pain just kicking off all the time. And mentally trying to deal with that, it's just so hard. So having the Peace Project in place has just been a lifesaver. I'm no longer isolated in my home. I'm able to speak to others who live with chronic pain. I'm able to support those who are more isolated than myself, because I can tell them that I've been in that position before. So as much as they see me now, I'm reminding them of where I came from. It's just taken time to get to where I am. And the Peace Project has helped us improve our chronic pain knowledge. It's helped us with self-management. It's helped us connect with people. It's opened up our eyes to so much different stuff which can assist us, because chronic pain is something that we will live with basically for the rest of our life. It's something that we have to learn to live with. And some of the people who attend the group haven't quite got to the point of recognizing or accepting. You've got to get to the stage of accepting that it's going to be there, because you kind of think to yourself, oh, if you're having a good day, you know, maybe it's not going to come back. And then tomorrow, bang, 10 out of 10, back to square one. So, you know, the Peace Project is something that has had an impact on my life. It's had an impact on the pain family's life, and the benefits are more valuable than money. Just knowing that somebody listens. I mean, one of the best things is that they actually listen to us. When we go to medical appointments, it's like a cattle thing, just rush through. Or the GP appointment is very quick, and they're not listening. And a few times I've had medical appointments, and they've prescribed medication that, in fact, I can't take because of my kidney. And it was my pharmacist who said, Angela, you can't be taking, you shouldn't have been described that. And I've had to go back in, and they've apologized. So, you know, I'm thankful that having the community involved is really important, because had the pharmacy not picked that up, I wouldn't have known, and I would have taken the medication, which would have then messed up the kidney. So, you know, the Peace Project, I believe, should be rolled out to help people not be isolated, but also for understanding as well, because so much people, as Professor Mark said, suffer from chronic pain, including children. I mean, there's children who are suffering now, whose parents are not listening, whose the school's not listening, and because it's an invisible disability, nobody's not listening. So I knew that I had to come and share with you all. You're all doing a great work in your profession, but listening to the patient is so important. You know, as Julia said earlier on, one size doesn't fit all. What might work for me doesn't necessarily work for somebody else, you know, and we all have to be active partners so we can deal with this, because this is something that's not going away, and it's also affecting our mental health. Most people who has chronic pain will have mental health because the depression, the anxiety of not being able to do stuff that you're used to doing. We're used to helping ourselves. When my pain's 10 out of 10, I can't do nothing for myself. I have to crawl on my knees to get from the bedroom to the bathroom because I can't stand on my feet. I can't put shoes on. And those things affect you because you just want to kind of get on with life, but unfortunately, it's not as easy as just doing that. It's something that's what we live with. So, you know, the medical team, I'm really happy that the Peace Project was founded, and I really believe that it should be rolled out so that other people who are experiencing chronic pain are able to be supported like I'm supported since joining the group, since going to the ongoing sessions and the support groups. It makes so much of a difference of being around people who actually understand what you're going through. So what I would like to leave with you all is, have you ever had a toothache? In fact, when you do have a toothache, I'd like you to remember me. That throbbing pain that's happening here and you're holding on to it like this, I want you to remember me, because that's how it feels over my body on a daily basis that I have to live with. So even though it's an invisible disability, it's a real disability, and something has to be done to make a change. Thank you very much for listening.
Thank you very much, Angela. It's very hard to change of topic after such a quite full of emotion talk. So thank you so much for taking the time and sharing with us your experience. Actually, talking about hidden disease, hidden symptoms, I'd like to introduce Professor Prashant, who is one of our professors in our school, but as well a GP by training, who study engineering, product design, and management. He's a mix of an engineer with a doctor. He has been working on very complex healthcare problems for many years, been trained as well in Stanford, and designed what he calls a frugal 5D model of innovations, being part of the commercialization of dozens of devices with teams all across the world. And one of the unique aspects of those teams is they are not 25 years experienced engineers or doctors. They are actually students coming from medical background, finance background, engineering, and they are now running their own companies and making a huge difference to many patients. So Prashant, we'd love to hear from you on how you manage to support all students at King's to design, deliver, and deploy a technology which is now available online, focusing on a very important problem in femtech. Thank you.
Thank you. Thank you for having me here. So, you know, this product is called Coolzen, and it solves a very, very interesting problem. And what I'll do is I'll talk you through the journey of it, the challenges, the joys, and how it works, how you can take it. So, as Seb just mentioned, I follow a model which is called the frugal 5D model. And this model is very simple. It's very intuitive. It's not about a professor who is very bright and sits in his ivory tower and has a bunch of ideas and say, I have an idea, let's go and fix it and create it. And then when you have created it, it becomes a TLA. We are all medics, right? We love acronyms. Technology looking for application. So I don't do that. What I do is very simple. Go put an ear to the ground and say, what are your problems? Which is the discovery, the first D, discover. And essentially, this is a phase which I use for very young people, not people with 25 years of experience, but people who are usually 25-year-old themselves, or less, 20 to 25, to go and say, how do my role as a teacher is, how do I make these young people fall in love with problems? Once I have done that, I don't have to worry about them losing hope and hopping from one grant to another, one job to another, looking at a raise of £1,000. Seriously, if they fall in love with a problem, then I don't have to do much after that. That's the first D, and that's the secret sauce. The second one is, people fall in love with a lot of problems. Some will take 20 PhD students working over the next 50 years to solve it. I'm a bit selfish. I say, I want to take 20 moonshots in my life. And I can only do it if each problem can be solved or we fail within 3 years. So then we go a very McKinsey-style process of defining, is this problem such a big problem that even a somewhat lousy solution will sell? Mark my words, somewhat lousy solution will sell. And I mean it. First products that we create, first versions, are somewhat lousy, but they sell. The third thing is design. It's again not 3 people sitting in a room doing a hackathon or something and saying we'll design it. We get real. We get people into a room, practitioners, prescribers, patients, users, not 2 or 3, not like a Kool-Aid or like a Band-Aid, 3,000 people. So I'll give you how many people we got engaged, and then we co-design with them, the products or the services. Then comes the next backbreaking tough phase, which is the develop, where I'll also run a quiz today in this group. I'm a teacher, right? So I have to deliver a quiz. And you raise some money, you hire more people, you fail, and then you build a product, and then you put it in the market, which is the deploy. At this stage, I leave the board of the company, go back to my classroom, and build another product. So I've been doing that for more than a decade, and it's now 16 companies, 14 products, 6 in the market. My only success metric is how many people did I help. I do a check on that every Christmas. It is approaching 2 million, so I think we're doing good. This is a story that I'm going to tell you today. Started with a B-Eng student who comes to me and says, I'm bored. I am not very excited about learning and not doing. So can we do something together? I said, sure. What do you want to work on? He said, well, I'm a girl. I'm very interested in femtech. We said, let's look at problems that afflict women. So we looked at one problem which afflicted women, and most likely will affect almost all of them, which is menopause. It's not a disease like pregnancy. I really hate it when people used to say pregnant women are patients. No, they're not. Menopausal women are patients. No, they're not. It's a part of life, and we have to make everything to make it survivable, pleasant, and livable. So we said this is a very good problem because we will have more than 1 billion users globally. Of course, I won't be able to reach them. Why this is important, if I put my management hat on and say, if I reach 0.01% of these people, I still have a tangible market to go and sell to and survive. So that's why a large problem. And then this is backed by research. So we worked together, and we found 2 very interesting things. And thank you, Angela, because what you said is what a lot of patients said. GPs don't listen. They don't have time. And it's not that they don't want to listen, but our first research was when we started hearing this, we did UK's largest ever research with GPs and menopause specialists, and we published it in the British Menopause Society Journal. It was so significant that RCGP, Royal College of General Physician Practitioners, and Royal College of Medicine reached out and said, we are going to use your paper. Can you give us the raw data of what doctors said about training that they have had for menopause diagnosis? And I'm very proud to say that the work with my student I is now informing creating training models, refresher courses for GPs for menopause. That's number 1. Number 2 was we spoke to nearly 3,000 women in partnership with a lot of NHS trusts across all the 4 nations of UK. It is the largest study ever done on menopause sufferers and people. And they said, we collected this data, and we asked this question, how long does it take for someone who actually goes into a GP to finally get a diagnosis that you had menopause. We thought it would be a few months. It turned out to be 3 years. They are referred to a sleep specialist, they are referred to a pain pathway, they are referred to a psychiatrist, and then it figures out that, oh, this is the problem. We also figured out that 80% of people with menopause have one common problem, which is hot flashes, which is a sensation of burning. For men who don't understand that, we have a jacket which has heaters inside it. You can wear that, come to my lab, we'll turn it on, you will feel it. I had to design that first to prove that it is a real big problem. And I took it to the parliament. Actually, this project got the second best award for a UK invention 2 years ago in the parliament. I've spoken and shown that there. So one line problem, there is no non-pharmaceutical solution that simply works for relief from hot flashes. So we said, okay, that's our definition. For this, a product will work. And we started designing. And if you think that someone needs to be a massive designer, no. These are my sketches of a woman lying down on a water mattress where I connected to a fridge. These are kind of crazy ideas we had. And then that was an aha moment. I said, of course, we are designing for women. I want to design a necklace. And then we took it to some women. They laughed at me. They said, have you lost it? They said, you have no clues what you're doing. I said, yes, sorry. Let us do something else. So came the version 1. We decided to not call it a version. We said it was version 0. Of course, we had to say it was bad. So we connected it to an app like everything else, right? These tabs are connected to an app. So we said, we'll build an app. But then people said, you mean to say if I'm having a hot flash, I'll take out my phone, play with my app? I said, yes, you're right. So this should not be that way. So then next version was a device which has an app to personalize it. Yes, I mean, AI is cool, but I would just limit it to saying it uses very, very simple machine learning algorithms to personalize the therapy for a woman. So how does it work is something for a longer discussion, but it's very simple. I use the 3 Rs, react, relief, repeat. It senses the onset of a hot flash. When you wear it around your neck, that's the product. It delivers a therapy, which is non-pharmaceutical. It's thermal neuromodulation, brings relief, and then waits for the next episode to happen. So women who would then have each hot flash episode lasting minutes now could sense that something happened, but it does not lead to a whole burning sensation and sweating, because burning sensation is the flaw in the thermal regulation, and sweating is body's response to bring the temperature down, and that's a whole bad cycle. I also paid some money to create a fancy video, which you can see for a product launch. I love product launches. So that's how the device is used. You put it into a strip, take off the biocompatible glue, connect it to the app. It does not need the app to work, by the way. Put it on the back of your neck, go about your lives, flaunt it, hide it, your choice. The second thing which we were still struggling with is, what do we do about this 3 years business of getting to hot flash? And we spoke to doctors, this whole business of co-creation. And they said that, people come to us for saying, I have backache. So how do I think it's menopause? I'm having a joint ache, so I think about it. So we created a tool called Unpause, which we say if you are having a patient who is of a certain age group, above 35, just ask them to spend 2 minutes on it so that they create a one-page report for themselves. It does not do any diagnosis. We don't want, I'm a GP, I would not like an algorithm that says, sorry, you're redundant. No, not like that. Makes your job better, easier, by saying, giving a checklist to the patient that, can you tell these 4 things to the doctor at the same time? I am having a patchy cycle. This has been going on for some time. I am having joint aches. That suddenly ticks this box in the GP's head. Could it be menopause? That's the only desire we had. This product is real. It's out there on the market. The app is on the App Store, and it costs £199. It's available on Amazon. We've just sold out our first batch. These are some real things coming from women who have used it. I'll let you soak it in. I don't like reading text off the slide. It has been life-changing for people who use it, and we invented a phrase, unpause menopause. Now, to just give you an idea of, I have a quiz, which is, From idea on a paper, yes, I have 1 minute and 6 seconds. Now 2 extra, because I was interrupted. Idea on paper, 1 more second. To impact, which is happy paying customers. This is a student of mine, Nitya, submitted her dissertation in May and said, let's do a company, July 2021. We launched this product in Feb 2024. I have a question for you to guess. How much of these 3 did I spend to get this from a sketch on a paper to the product in the market? 3 million, 5 million, 10 million or more? 3. Okay, so what I do is I do frugal innovations, absolutely lean organization, frugal methods. It took us 300,000 pounds, that's it, to build it from a sketch on a paper to product in the market. And we are still running a community pilot. If you'd want to offer a free device to your patient, friends, family, or even yourself, scan this, submit a request. I'll hold this on for 5 seconds, and we'll do that. Now, I know this is being attended by patient advocates, clinicians, and others, and I want to take this opportunity to market something, which is a program from KHP, which is if you are a healthcare provider, it could be a nurse, a physiotherapist, anybody, with my colleague and friend, Rachna. Where are you in the room? If you could say hello to everyone. We run a program called CLIP. CLIP because it can loosely hold things together, and also it is a fancy acronym for Clinician Innovators Program, where we bring together you, the engineers, people, designers, to come together and solve problems. How can you get connected? Second thing to scan, which is here. If you scan this, and you will be added to a list, I promise. I won't know your number, you won't know mine. So completely GDPR compliant tool, where we could send you information of next iterations of CLIP. And I'm about to finish. This is my last slide, I promise. And here is my mission in life. I'm best defined by my mission. I have a simple mission. I want to reach 10 million patients by co-creating 20 medical technologies by the end of this decade, 2030. Help me reach that. You can connect with me here. And if you have a problem, I look at it as an opportunity. We have the LIHE, the London Institute for Healthcare Engineering. I have fabulous colleagues who are very supportive, like Seb, of turning problems into products that solve at very, very affordable costs. I think that's what NHS needs. Thank you so much.
Thank you very much, Prashant. And you can see how Prashant loves acronyms as well. And one of the questions, and we don't have time, I've been told, for Q&A, and we will have to move on to the next session, but just only one seed of an idea. Of course, I already discussed with Prashant is how about using this technology for patients who are going through hormonotherapy and who are male. And there is quite many of those who have hot flashes all the time, and we're going to try this.
Absolutely. The one product is on the way to a potential user.
Yeah, exactly. So I would like to thank again all of our presenters. Thank you so much for your time. It was extremely enlightening. And now I would like to hand over to Professor Anne Pollock, who will introduce the next session in about 1 minute. Thank you.
Yes is more than just like some type of intervention for people with diabetes. It's much more than that. And I feel like everyone who has diabetes or knows someone with diabetes should go onto it so they can be more enriched.
It's an exciting time to be a sickle cell nurse specialist. I'm very proud of what I do. To me, it's actually one of the best jobs in the world you can have. And I've done loads of work in my life, so this is the job as far as I'm concerned.
We've got to remember that every 2 minutes, a pregnant woman is dying somewhere worldwide. What we do know is that in the United Kingdom, our maternal mortality rate is rising. That's just not good enough.
People don't often get to exchange their ideas and their research and their day-to-day lives. So I think it was a really special event for that reason.
Hernias are one of the commonest surgical procedures performed all over the world. and it's like the bread and butter for general surgery. So it's a good training opportunity for trainees to come and do the hernias in a relaxed atmosphere and give them the option.
So what does the Mind Motion Go? It allows patients to exercise in a gamified environment. There are over 35 different games designed by clinicians, all designed for patients with neurological conditions.
Yes is more than just like some type of intervention for people with diabetes. It's much more than that. And I feel like everyone who has diabetes or knows someone with diabetes should go into it so they can be more enriched.
It's an exciting time to be a sickle cell nurse specialist. I'm very proud of what I do. To me, it's actually one of the best jobs in the world you can have. And I've done loads of work in my life, so this is the job as far as I'm concerned.
We've got to remember that every 2 minutes, a pregnant woman is dying somewhere worldwide. What we do know is that in the United Kingdom, our maternal mortality rate is rising. That's just not good enough.
People don't often get to exchange their ideas and their research and their day-to-day lives. So I think it was a really special event for that reason.
So it's such a pleasure to be with all of you here today. As was mentioned, my name is Anne Pollock, and I'm the head of the Department of Global Health and Social Medicine, which is a department that does social science of health and medicine, located within the Faculty of Social Science and Public Policy. And it's been a real pleasure for me to serve as SSPP's kind of representative and conduit between King's Health Partners and social science and public policy. And population health in particular represents a call for us all to complement the clinical interventions that we do for the patient in front of us, with a commitment to doing more than just sending them back out into a world that makes them sick. With my own students in Introduction to Social Medicine, I talk about the history of this trend. So a really important kind of person within the history, both of cellular pathology and of what we call social medicine, is Rudolf Virchow. And he both helped us to understand what it is in cellular pathologies that can make us sick, and also the ways that political and social inequalities can make people sick. He was doing this in the 19th century. And he argued that if medicine is to reply and accomplish its great task, it must intervene in political and social life. It must point out the hindrances that impede normal social functioning of vital processes and their removal. So Virchow is this 19th century polymath, and he seeded this vital conversation, but he could only go so far in his context. A lot has happened since then, and yet there's a lot left to do, and I think King's Health Partners is really well situated. So working across the interdisciplinary academic, clinical, and wider domains, it's really ideally situated to bring about social and medical transformations that can more fully realize health for all. Inequality itself is pathogenic. And if we are to achieve health equity, we must work across scales. We need to look at the cells and the molecules, even smaller. We need to look at bodies. We need to look at health systems. And we need to look at broader social structures. This is something, of course, that we'll delve into much more in the afternoon sessions as we get into health inequalities, but we're really starting that conversation here and now as it's central to population health. And today's panel is an incredible instantiation of this, working across medicine, epidemiology, lived experience, and advocacy. And so with that, I will hand over to our first pair of speakers, who are Das-Munshi and Dan Barrett, who are the co-directors of PHI UK Population Mental Health Consortium, who will be presenting together.
Great, thank you very much. So I'm Das-Munshi. I'm a professor of social and psychiatric Epidemiology, and over the next 20 minutes or so, we're going to talk to you about how we think mental health equity can be achieved through partnerships, data and policy. And I should say this talk is going to be with my colleague, Dan Barrett, who's Director of Thrive London, and we co-direct a brand new population mental health consortium that's nationwide. So to an extent, we're going to be sharing our vision with you of how we think we can achieve this. So I'm going to start with this first slide. Is it changing? There we go. So no health without mental health. So this is a proposition that I think most of you in the room, if not everybody, I hope, has heard before. And the reason for that is because back in 2006, almost 20 years ago now, the WHO first raised this proposition in order to bring mental health out of the shadows of stigma and discrimination. Because we know that mental health conditions are extremely prevalent in the population, and we also know that up to a fifth of years lived with disability worldwide are due to mental health conditions. And people who have mental health conditions face very tricky, adverse social and economic outcomes. So in the last 2 decades or so, there has been a bit of a shift, potentially, because I'm seeing around the room people are nodding, and this is not that, this is something that we've all heard. And perhaps stigma has been shifted a bit publicly, but I'm going to suggest that we're still lagging in terms of thinking about this in terms of our broader public health agenda. And this is exemplified by a very small amount of money spent on prevention. Only 3.9% of research in mental health is spent on prevention. So we need to do more to think about how we can shift to the left and spend more on preventing the onset of mental health conditions. Unfortunately, not all things are equal, as Anne was suggesting. I mean, some work that we did looking at psychological distress in populations during the pandemic, we looked at 3 separate cohorts of people followed up over time, and we found that there was a shift in more psychological distress in the first year of the pandemic as a whole, across 3 different surveys that we did. But what was really marked was when we break it down by gender, most of that psychological distress was being experienced by women. And that's because in that first year of that pandemic, if you recall, women were pretty much making up a large proportion of the frontline effort as we were tackling this public health emergency. Women also shouldered most of the caring responsibilities, children as well as older people. And we also know that certain experiences like intimate partner violence, which disproportionately affect women, became more prevalent during the pandemic. I've been told to walk back a bit. So it's not just women. Our work's also highlighted that racially minoritized people who are minoritized by sexual orientation, people who lived in more deprived areas, and even younger people are much more likely to experience mental distress, particularly in this pandemic context. So inequities need to be at the heart of what we do, and we need to attend to this. So I'm going to move ahead and say that the way we do this would be to focus on 3 specific challenges. So the first challenge should be a focus on children and young people. And that's because we know that half of mental health conditions have already happened in children and young people by the age of 14, and 3/4 by the age of 24. So if we want to really prevent this, we need to shift a bit earlier in the life course. Challenge number 2, suicide and self-harm. 6,000 deaths annually due to suicide. This is a huge number, and it has measurable societal and social consequences. And as this figure shows, there is a heavy association with deprivation. So in the more deprived areas at the top of the figure, you can see that there is a higher standardized rate of suicide, and as we move into more affluent areas, the levels drop. There are strong age patterns as well. So this figure, which is a heat map, shows the patterns of suicide by age, starting in around the 1980s on the right-hand side and moving towards present day. And you can see the dark areas show higher levels of suicide in older people, but as we move towards the present day, we find that actually most suicides in the UK are now under people who are aged 50, and actually more in men than women. So there are differences in the population that we need to attend to. Suicide and self-harm is a challenge because there are good public health interventions that can tackle this, and so this is another area that we should focus on. And challenge number 3, multiple long-term conditions. We're all living longer, and as we age, we're more likely to live with 2 or more long-term conditions, which are mental and physical health conditions. And as this figure shows, as people develop more physical health conditions, they're much more likely to develop mental health conditions. And this also follows a strong social gradient. So the line at the top are people in the more deprived areas, and the red line, and as you move down, you can see there is a strong social gradient into the more affluent areas where people experience less mental and physical health conditions. So this sort of figure kind of underlies what we need to do, which is essentially an approach that cuts across a very traditional single disease framework. We need to join things up a bit at the population level. So what are we going to do about this? We asked this question a while back. We undertook a systematic review because to try and find the sorts of population-level interventions that can help us to tackle this. And we decided to do this by using a social determinants framework that you can see here. This was a piece of work developed by Crick London colleagues, but really speaking to the social determinants that impact mental health across 5 domains. By social determinants, I mean the sort of environmental context that structure people's experiences and then can put them at risk of more mental health problems. And across those 5 domains, we found a lot of studies. We looked at more than 100 reviews. And if you're interested, by the way, the QR code's at the bottom. But what was quite interesting across all those 5 areas, there were only really 1 or 2 very good evidence-based interventions that we could suggest tackle this. And in some of the domains, the neighbourhood domain in the middle, we didn't find any interventions. It's very difficult to do work in this area, and that's because sometimes it's not ethical to randomise. So if we want good evidence base, we generally try and randomise the clinical work, and that may not be ethical in some contexts. Lots of studies don't follow people up for enough time to be able to show a difference, and a lot of the time in mental health, the studies are too small to detect a difference. So if we want to move this area, we might need to think about using a different approach. And we traditionally tend to develop the evidence in the way that I showed you, and then we hope that eventually it'll start to impact on policy. But what I'm going to suggest is that in the UK, we have some of the best data sets in the world, both representative, national surveys, cohorts, and we're rapidly developing resources that capture people as they interact with health services, social care, and a lot of these data sets are being linked. So we have an amazing observational repository of data, and we're also developing methods that can help us to understand if what works at the population level really has an impact to lead to good mental health for all. So I'm going to suggest that we can actually turn this on its head and start with policy and move backwards and look at the data to help us understand what works for all and to really drive what we do next in terms of evidence. So I'm going to hand over to Dan now, who's going to tell us how we're going to achieve this.
Try. Right, hello everyone. Yeah, I'm Dan. I'm not an academic. I come to co-leading our consortium alongside Jay as somebody with lived experience of mental challenges and neurodiversity. I bring my passion as an activist and a campaigner around various causes and my experience leading large-scale health programs, most recently as the director of Thrive London, which I've been doing for about 5 years. So these are complex and challenging times for public health, but there is also opportunity. And we're at a crucial moment where we can forge new pathways towards better mental health for all. Fundamentally, I believe that good mental health is not simply an individual concern, it is a right and it is a public value that lies at the heart of our shared humanity. It does not exist in isolation, but it is interconnected with every aspect of our lives, shaped by social, political, economic, and demographic forces, and our approach must reflect this complexity. Thrive London does various things which I'm not going to go into, but we are particularly interested in infrastructure change, so influencing and creating channels and processes that affect how change occurs to move us towards more equitable, more sustainable, and more long-term change in the public mental health landscape. An example of this is our work around suicide prevention. We've been running a regional suicide prevention group since 2017, which brought together over 40 organisations alongside people with lived experience and community groups to develop data-informed regional programmes that enhance the work of partners right across London. Together, we've created real-time surveillance systems, we've delivered targeted interventions, large-scale training programmes, and regional campaigns like our Zero Suicide London campaign. We understand that mental health is driven by complex systems of factors. Addressing it requires interdisciplinary, systems-based approaches, and effective solutions must consider the interplay between policy practice and lived experience, backed by solid data. And that brings me on to our consortium. So Jay has demonstrated the imperative of our consortium, the critical gap that must be addressed if we aim to create meaningful change in population mental health. What excites me most about Jay's vision is the unique opportunity to intentionally do things differently. If we are to achieve meaningful change, we must democratize knowledge production, challenge the assumptions and power relations that perpetuate inequality, integrate diverse and intersectional perspectives to close the gap between evidence, policy, and practice, to pave the way for new approaches in mental health, and ensure that lived experience guides how evidence is produced and how policies are made to improve the relevance and effectiveness of interventions. This initiative enables us to collaborate with world-leading academics and data scientists right across the UK to establish an interdisciplinary and distributed infrastructure to identify, prioritize, and evaluate population mental health interventions. One which operates intentionally through an equity, diversity, and inclusion lens, underpinned by large-scale linked data systems, novel and rigorous methods, training and capacity building, and the involvement of communities, policymakers, practitioners, and people with lived experience. We've established a cross-functional core team to bridge the gaps between all these organizations and recognize the different expertise to set common goals and collaborative ways of working. By adopting an agile approach, we're challenging traditional hierarchical structures, fostering trust and innovation. I'm just going to talk about two aspects of the consortium in a little more detail. Our strength lies in our partnerships. And so fundamentally, it's about creating a coalition across lots of different sectors with people with lived experience, collaborating with local, regional, and national government, policy and practice partners to create this ecosystem, this infrastructure for how we improve mental health. To enhance involvement, dissemination, and impact, we're co-developing engagement events and policy roundtables right across the UK to bring together broad stakeholders to collaboratively set our research agenda and develop actionable recommendations with us. We're committed to ensuring that our initiatives are inclusive of individuals who've previously not engaged with population health or research. So to support this, we'll be running a number of Sandpit events with associated grant schemes to particularly welcome interdisciplinary academics to work alongside community groups to propose, take forward, and evaluate new ideas. We're also integrating an embedded peer researcher methodology and an artist researcher to ensure that individuals with lived experience work alongside academics to co-design and co-lead our work, provide strategic guidance, and through creative methods, improve the accessibility of our research. The second area I just want to focus on briefly is narrowing inequalities. So to address mental health inequalities effectively, we must focus on underserved populations and ensure our participation is inclusive of diverse communities. This is vital for asking the right questions and delivering meaningful solutions. Our goal is to create inclusive, data-driven systems that support all members of society, especially those most in need. EDI is central to our approach. Co-produced research that integrates an intersectional lens can reduce inequalities, enabling us to develop rigorous methods to assess intersectional disparities in mental health. And we'll utilize a health inequalities assessment toolkit to map those inequalities, prioritize evidence for action, and ensure accountability in tackling identified disparities. We're obviously at the beginning of this journey. We only launched a few months ago, but as we embark on it, we're ambitious about what we can achieve in the coming 4 years. My hope is that we cultivate a strong, effective, and sustainable partnership amongst policymakers, practitioners, people with lived experience, and researchers, one which sets new expectations for research practices capable of being replicated in other domains of public health and research. We aim to tilt the playing field for individuals with lived experience and to the associated discrimination and inequalities, And we're also acutely aware of the evolving policy landscape, particularly following the recent regional and national elections. The Mayor's London Growth Plan and London Missions, alongside the National DARSA Review, presents compelling opportunities to integrate population mental health approaches into broader initiatives. So, in summary, our mission is clear. We must redress the balance towards prevention in mental health. By engaging diverse voices and perspectives, we can close the gap in health inequities, building a mental health ecosystem driven by data, lived experience, and interdisciplinary collaboration. And on a final note, I guess what Jay and I want to say is our consortium is open, intentionally so. Whether you are a researcher, a policymaker, a clinician, a practitioner, or somebody with lived experience, we invite you to get involved. Help us shape our research agenda, ensure it answers the questions, the population mental health questions that matter most to you. Ensure that it leads to evidence-based policy frameworks which prioritize prevention and improve people's lives. Let's work together to forge a future where mental health is recognized as a human right and a public value. Understanding how inequalities shape people's opportunity for good mental health is critical in moving away from an individualistic view of mental health experiences. Your involvement is essential in validating lived experiences and challenging traditional hierarchies of knowledge production. Together, we can ensure that no one is left behind through this work. Thank you for this opportunity, and thank you for your commitment and support as we embark on this journey together.
So thank you so much to Jay and Dan for this really inspiring interdisciplinary and multi-domain engagement around population mental health, which I think is a really fantastic model for the ways that we can do this work that has the real potential to not only create an evidence base, but also transform policy and improve the experiences of those with mental health disorders. We're actually like oddly a little bit ahead of time. I think that's fine. But that's fantastic because we now have our second group of speakers who will be the last thing before lunch. It is really a privilege to welcome Subarna Chakravorty, a consultant hematologist at King's College Hospital and NHS Trust, who will be then also inviting Ronke Dosumu, expert in experience. So I'll hand over to you.
Thank you very much. So I'm just going to use some slides. Thank you to KHB for inviting me to talk, me and Ronke to talk in this conference. I'm really delighted to be here. I was a little bit drenched, but in the next few minutes, I'm hoping to give you a little bit of an overview about what. So I'm a hematologist, but my primary area of interest in both clinical and research is sickle cell disease and thalassemia, but I'm going to focus mainly on sickle cell disease. And some of you will know that sickle cell disease is a chronic health condition involving the red blood cells. Ronke will talk a little bit more about her lived experience with sickle cell disease, but I will start by giving you a little bit of information about sickle cell disease in London. So you may not know this, but about 15,000 people in the United Kingdom suffer from this condition, which is slightly more, about a third more than people with cystic fibrosis. Both are similar. They are inherited conditions. They are conditions that it's an autosomal recessive disease, so you need two affected carrier parents to have an affected child. About 60% of all of these patients reside in London. So we in London have a large number of patients that we care for. And about 1 in 35 babies born in London, so that's a large number of babies, so 1 in 45 babies, regardless of ethnic origin, regardless of anything, 1 in 35 babies who are born in London today carry a gene, is a sickle cell gene carrier. And about 1 in 1,000 babies in London are affected, and newborn babies are affected with this condition. And Londoners with sickle cell disease mostly are African, Caribbean, or Middle Eastern heritage. we see normally about 30 years reduction in life expectancy in sickle cell disease. And that is a staggering gap that still needs to be narrowed. In the 70s and 80s, it was virtually a childhood disease because nobody really survived through to adulthood. And one of the hallmarks of sickle cell disease is debilitating pain. So unfortunately, we have seen over the longest time, huge inequalities in the quality of care received by patients with sickle cell disease. Huge numbers of failing of care with sickle cell disease. There were some really high-profile ones in the last few years. 21-year-old Evan Nathan Smith died in North Middlesex Hospital in 2019. He had to call an ambulance from his hospital ward because he was not able to get oxygen. Tyrone Ayers' death from morphine overdose occurred during a sickle cell crisis in Northwick Park Hospital. This is all in the public domain in March 2021, and investigations indicated that too was avoidable. And when you talk to people, you hear, and when there is investigation of near-miss reports, we see that a number of Tyrones and Evans were possibly very narrowly avoided. The main thing that people tell us, and we have done extensive work on patient-reported experience measures, people tell us that there is lack of timely pain relief, there is lack of empathy during the care they receive when they're acutely in pain, and often they are accused of being drug seekers. And people will, this is a lived experience which I'm sure Ronke will have lots more to say about. And people will only go to emergency department if they have exhausted everything else, every other option. So following Evan's death, unfortunately, there was a report called No One's Listening. And it really is a very appropriate name of the report. It was called No One's Listening. It was published in November 2021 by the All-Party Parliamentary Group on Sickle Cell and Thalassemia. And it gives you has given us a large number of very sensible, reasonable, and doable interventions that we hope will improve that sort of stark inequalities that we see in patients receiving care. And we in King's Health Partners have one of the most deprived, our home to one of the most deprived boroughs in the country. And you will find, and unfortunately, we see that many of our patients who we look after in our hospitals in KHP tend to come from quite deprived backgrounds. So there is a huge list of recommendations from the No One's Listening report, of which the big highlight was the substandard care that they received in A&E and general wards. And quite a number of interventions we have done in KHP to actually address some of these, and I'll highlight them in a minute. There was advice that there should be some sort of communication between A&E department and secondary care teams. So we have got care alerts now in place, and hopefully that will be London-wide. There was a significant amount of work is currently happening, both within KHP as well as in wider London. A big piece of work is being led by the NHS Race and Health Observatory, trying to really understand how people's attitude towards patients who are from minoritized backgrounds can improve. And this has been, research has shown so many times that simply by being from a minoritized background automatically makes you, the time that is needed for you to receive pain relief at the time of extreme pain is increased by about 25%. Within KHP, we've done an enormous amount of work in the last 2 years to try and address some of these issues that was raised by this report. So we've created a trust board, which is chaired by the chief nurse at GSTT. We are accountable to the board, and we are, we present to them problems that our patients are facing, so that they can be things can be easily resolved. We are working very hard to deliver pain relief within 30 minutes of them presenting. This has been a nice guidance since 2012. We're working with A&E and we've developed many educational resources. And one of our educational resources, again, supported by KHP Haematology, is now being taken up by the whole country through NHS e-learning for health, which will allow users, which has, it's co-produced films, which now providers are learning from users how they want to be treated when they come to A&E with pain crisis. We've got some e-alerts in our clinical EPIC system, which is the patient note systems. We're being told about patients as soon as they come into the hospital. So that's been really helpful. We also have within KHP Haematology something that we're very proud about, and it is a virtual organization at the moment. We call it the Sickle Cell Center of Excellence, but we may call it something else. It was established a few years ago with a big ambition within the sickle cell provider teams, both at King's College Hospital and Guy's Hospital, to bring together all the various aspects of sickle cell care as well as sickle cell research, there's a lot of pioneering research happening within this organization, to bring it together to provide a lot more than what is simply commissioned and delivered by the NHS. So we have what's now being called a quadrumvirate of research, education, clinical excellence in delivery of care, as well as implementation science and discovery science. So together we have this vision that we will make living with sickle cell within our area in Southeast London a kind of an exemplar for the whole country, if not the world, to follow. So we have a massive ambition, and some of our colleagues from KHP Haematology are present here who are aware of this, and we would be interested in talking to people here and perhaps after the meeting to see how KHP is supporting us and how we can work even more to get us to realize our ambition. And so what have we done so far in the last couple of years that I've been clinically leading this program? So we have delivered successful preceptorship programs. So we've been doing quite a lot of education. We've been very fortunate to have a project called Aging Well with Sickle Cell Disease within that was funded by King's College Hospital charity, where we are truly co-producing a pathway of care that patients with sickle cell disease who are aging, because more and more people are living longer with chronic health conditions, including sickle cell disease, but our patients age much quicker than people with, without sickle cell disease. And we kind of consider frailty within sickle cell disease to start at about 35 to 40. So anything beyond that sort of age, we want to understand how best we can support frail, older sickle cell patients to live their best lives. We have put together quite a lot of grants, both for molecular as well as clinical research. And the fact that this kind of umbrella organization has allowed us to work together, both Guy's, King's, as well as our partner organization, Lewisham, Woolwich, etc., has been fantastic. We have a massive ambition for patient and public partnership. We have already got some grant funding from Genomics England, and we are meeting with our patients regularly who are advising us how we are providing our clinical care as well as shaping our research priority within our organization. So that's been an excellent achievement. And this is just a quick summary of the Aging Well project. We really want to co-produce a care pathway and solutions, interventions that will allow patients with sickle cell disease to live well within our catchment and hopefully beyond once the learning is available. And I just want you to see the numbers, quite staggering numbers really, of the degree of comorbidity. And this is some work that is ongoing within our organization. It's the sickle cell long-term natural history follow-up. And you will see that for patients over 30 years of age, of 344 patients, a staggering 20% have chronic kidney disease, and this is, truly quite remarkable. We have 55% with retinopathy. We have a quarter with joint problems, 20% with pulmonary hypertension, 16% with acute chest syndrome, which is a specific problem with sickle cell disease. So we are facing significant burden of disease amongst our surviving patients 30 years or older. And this is something that we are only just beginning to understand. This is, for the longest time, sickle cell used to be a childhood disease. Now that patients are living longer, we are really, on the basis of this and our Aging Well project, we're hoping to develop a framework where we can actually start thinking about how best to support our very young patients who are quite frail. And then there are some other London-wide interventions, which I'm going to quickly whiz through. We've got an ACT NOW acronym, a bit like, there are various acronyms that are allowing people to have the sickle cell in mind, the acute painful crisis in mind when they're coming to A&E departments, and a huge amount of work is being done to make this, the education happen within London. We have established now a London Sickle Cell Improvement Programme Board, which I am part of it, and we are looking at emergency department bypass pilots, prescription charges, communication drive. We undertook that. There's an universal care plan program where every patient with sickle cell disease will have their pain care plan universally accessible by every point of care delivery in their pathway. This was a London-wide program which was initially just for end-of-life care, but now sickle cell disease has been co-opted into it, and the GIRFT program as well. I'm just going to quickly go through this. Within South East London, we've now also received a £2 million pilot to improve the work that we're providing, improve the service that we're providing in the community, and we have now recruited all the members of the MDT in the community, including dietitian, pharmacist, physiotherapists, etc. That's taken us about a year to recruit. We're hoping that we're going to collect enough evidence that will allow our ICBs to continue to commit to make these positions long-term. Universal Care Plan, I've briefly mentioned already that anybody with sickle cell disease, if they ring 111, ring the paramedics, the London Ambulance Service, A&E departments, will all have access to their pain care plan, including the NHS app. So the patient themselves will have access to their pain care plan through their NHS app. And right now we are at the phase of design where we are where with the patients, we are discussing to what degree the editable functions of this app is going to be available for our patients. And finally, I want to finish by giving a background to Ronke, what Ronke is going to tell you about. So knowing what we know about sickle cell disease now, you know that it is a lifelong disease, you know that people are living longer, but with a huge burden of disease. And so far, we've really only bridged a very tiny gap in terms of the life expectancy of our patients. So really our real opportunity here is to provide a cure for our patients. And we're very, very proud that we're able in South East London in King's Health Partners to be able to provide adult sibling donor bone marrow transplants, which I'm a clinician that provides this service. And that has been in place since 2019. It's 15 years later than many other international organizations, particularly in the US, but through an enormous amount of work done by colleagues, this has now been an approved policy since just before the pandemic. We started in 2021 at King's and have done the most number of bone marrow transplants in the country since then. And then there are some new horizon things in the horizon, so gene therapy. Gene editing has now been approved in the UK for thalassemia, and we're hoping that will be available for sickle cell disease as well. Another form of curative treatment. And within King's Health Partners, we are now undertaking a study called the Redress Study, which is allowing us to widen the source of our bone marrow transplant donors. And there is another study that we are just trying to put together a specific King's bone marrow, gene therapy study. So one thing that we definitely want to learn from our patients in the curative space is what does cure actually mean in sickle cell disease? And I really want Ronke to talk to us through that. We want to, within our Sickle Cell Center of Excellence framework, think about what are the priority of research within Southeast London, King's Health Partners, and how can clinical care be informed by translational and discovery research within KHP hematology. And we've talked about that in our previous speaker as well. And we've co-created lots of videos, etc. And I would really like to now hand over to Ronke just to tell us a little bit about her experience. And Ronke, I'm very pleased to say, is now officially cured of sickle cell disease. She, well, I'll let you take over from here and tell us your wonderful story.
Thank you.
You don't have anything.
Thanks for having me here today. So as Dr. Subarna said, I am officially cured from sickle cell. Just a little backstory. I am one of 5. So my older brother actually died from sickle cell. I was told from the age of like 8 that I wouldn't live past the age of 21. So I'm grateful that I'm here to sort of like share my experience because I'm now 32 and it sometimes brings tears to me because I'm just like, I've gone through so much and like, I'm grateful to be here. I had the opportunity to have gone through the bone marrow transplant as well. So I wasn't born in the UK. I sort of like moved here with my mum and my siblings quite young. One of the reasons was like health system back home isn't that great. So coming here, I've gone through a few examples of sort of not being treated well. I guess that was also due to lack of understanding of what sickle cell is and how it affects my body and what it means for me. Growing up, having to go to like school and then going into the workplace, I feel like a lot of employers didn't really understand when I would be like, I can't come into work, or like making my way to work and then literally just collapsing in pain because it's so unexpected. So throughout my journey, working with Dr. Subarna and also a few other nurses, the support that was being provided for me were amazing in terms of their care and understanding what it is. But few experience in A&E hasn't been great. I've had 3 near-death experience. And there's been time that I feel like, you know what, like, I don't think I can make it. I can't see a future. But through the support that I've gotten from like the specialist nurse and my consultant, I'm honestly grateful to be here and to have the opportunity to sort of like share my experience and to also sort of like thank them because they don't go through what I go through, but to be able to relate to that and to have the passion that they do to sort of like push and advocate for us, it's honestly words can't explain. And which is one of the reasons why I said I'll do whatever I can in my power to sort of like advocate for people that don't have the voice, or people that are going through what I'm going through and can't speak as well as I can. So I've worked with Dr. Subarna, obviously through my journey of getting the stem cell transplant, having my brother who was like 100% donor match, not just only down to the cells, like I guess there's a lot more to it that I'm not really aware of, but going through that process was really hard and really tough. Obviously, I wasn't really sure of like what it exactly entailed. I knew that I was going to do chemotherapy, I knew I was going to do radiotherapy, but I didn't know the side effects that can also come with that as well. So obviously losing my hair, that's like minor. Having extreme headaches, I felt like my brain was going to explode. I didn't know that that could be side effects of it. Obviously, infertility, those kind of things, I had to sort of like weigh my options and be like, at the end of the day, I want to be able to live. Like, I want to be able to achieve the things I want to be able to achieve. With employment, I had to become self-employed just so that people can sort of not put me in a box of unreliable and not hardworking, because I work so hard. Don't want to cry.
Don't push yourself too hard.
Sorry.
I'm sorry.
It hasn't been easy, but I'm so grateful to be here and to sort of like share my experience. And yeah.
Ronke has a lot of achievements. So you work in a
Yes, I work in a consulting firm. I also have my hairstylist.
She's
company.
a fabulous hairstylist as well, her own company.
So I've been doing a lot of things, and I feel like sickle cell has held me back from achieving a lot, held me back from reaching the goals I want to reach. But now I have the great opportunity to sort of like soar through the sky and like get the achievement that I want, and always.
You're always a very high achiever, Ronke. Always you're pushing yourself, but yeah.
Yeah, I feel like there had been limits, but now like the cuff is off from being limited and not sort of like planning to the T what I'm gonna wear. Is the weather okay? Like, am I gonna end up in hospital? Like, I don't have to worry about all of that, which I'm so grateful for, like all the research that's been done and opportunities and the charities. Yeah, like. I just wanted to say thank you, and thanks for having me here today as well.
Thank you so much to this really, really moving set of conversations. I think that it really speaks to the way that, sometimes those who treat diverse patients talk about, oh, what's going on? Why don't our patients trust us? We need to cultivate trust. We need to then, to have deal with this problem of distrust. But I think that what Subarna's comment about the long delays in pain relief and the egregious lack of care, even when we have the NHS and we officially have care, right? We still have these barriers. It's really inspiring to see the ways that we're not only trying to get patients to trust, but build institutions that are trustworthy. And once we build institutions that are trustworthy, we'll be able to really achieve a lot more of these positive health outcomes across physical and mental health. And so we don't have time for Q&A in this session either, but hopefully we'll be able to continue these conversations over lunch, which is just across the way. And thank you so much.